Marcus, a 20-year-old medical student, has recently started learning how to program. He is also learning French, how to play the piano, violin, and guitar. He has recently failed 2 of his exams. When you're speaking to him, he seems very hyper and is very excited about his plans for the future. His speech is pressured, and he reports having racing thoughts for the past 2 weeks. Do you know what diagnosis this is? This case illustrates bipolar type 1 disorder. Do you know why? Well, bipolar type 1 disorder involves at least one manic or mixed episode. It usually requires hospitalization, and it lasts for at least 1 week, and it causes significant distress or impairment in a person's functioning. What is the other main type? The other main type of bipolar is type 2. This involves at least one major depressive episode and one hypomanic episode. Hypomania is basically a less intense form of mania, but has the same symptoms, but does not involve marked functional impairment or psychotic symptoms. Patients do not meet the criteria for full manic or mixed episodes. Bipolar type 2 is characterized predominantly by depression, with occasional hypomanic episodes. A good mnemonic to remember the symptoms of mania or hypomania is DIGFAST. So DIGFAST stands for distractibility, insomnia, grandiosity, flight of ideas, activities, sexual promiscuity, talkativeness. So when I say grandiosity, I mean there's an increased self-esteem, more goal-orientated. You can actually see patients who think that they can achieve multiple things at once, or that they're the king of Spain, so they can dip into psychotic symptoms as well. So a manic episode is 1 week or more of persistently elevated or irritable mood, plus 3 or more of these DIGFAST symptoms. Psychotic symptoms, like I've already mentioned, are common. So, in terms of risk factors and epidemiology of bipolar, the prevalence of type 1 is approximately 1%, and the prevalence of type 2 is approximately 3%. Males and females are affected equally. A family history of bipolar disorder significantly increases the risk. The average age of onset is 20. Frequency of mood episodes increases with age, and 10 to 15% die from suicide. So how do we treat patients? So there are 2 schools of thought for treating bipolar patients: mania and depression. Beware, if you prescribe an antidepressant without a mood stabilizer, you may trigger a manic episode. So let's start with looking at mania. This is considered a psychiatric emergency because of the impaired judgment and great risk of harm to others or themselves. In the acute setting, antipsychotics such as lithium or sodium valproate are particularly useful. Long-term therapy, you're going to be thinking of mood stabilizers, so the first line would be lithium. Bipolar depression requires mood stabilizers with or without antidepressants. So the last thing I want to look at is what are some differentials for bipolar? Well, it could be schizophrenia, it could have a personality disorder, or it could also have something called cyclothymic disorder. So cyclothymic disorder is a chronic mental health disorder which is characterized by alternating periods of hypomania and moderate depression for greater than 2 years. It can be very difficult to distinguish from bipolar type 2, and that is one of the difficulties. So that's the end of the lecture. Thank you very much for listening. I hope it was helpful in kind of understanding mood disorders. And if you have any feedback, please let me know. Thank you very much.
Guys, thank you very much for watching. Make sure that you like this video if you like it. If you don't like it, then do unlike. Like this video, subscribe to the channel, and please share this channel with others as well.